Thank you, everyone. I'm Amit Sethi. I'm a faculty member at IIT Bombay, and as Dr. Neeta already introduced, I work in deep learning. I also am a visiting faculty at UIC Department of Pathology, and that's a little bit of an odd combination, and that's because of the work that I've been doing in pathology with some collaborators there at UIC, University of Illinois Chicago. So I develop algorithms that primarily work with whole slide images for cancers, and this is what I will talk about. I'll give a brief introduction about different hierarchies of tasks that we can do with AI, and then go a little bit about demystifying AI and what are the challenges in AI. What is the AI life cycle and how it can help doctors, and how doctors can also help develop AI. So when we talk about AI, there are different tasks that we can do with AI, and some are simpler, some are more complex. And as we go into more complex tasks, the value that we get out of AI is going to increase. So, for example, if we see a medical image, could be a radiology or a pathology image, to find different structures such as where is the DCIS in breast cancer pathology, or where is a particular organ in radiology. That is something that AI can now do fairly well, given that if we prepare a lot of data for it to learn from. So that is one part of it. And then if we want to make the task more complicated, we can train AI to mimic experts in diagnostic tasks. So for example, not just mark where DCIS is, but also classify between DCIS and then invasive ductal carcinoma, for example, or in childhood cancers, for example, if you have retinoblastoma or not, or some other eye condition that could be used to classify between those two. And then we can make the task even more complicated, and start to extract information which is usually not very reliable for human experts to extract. So for example, there is early evidence that we can recognize even certain mutations, not all mutations, but certain mutations from pathology and some even radiology images. There are subtle changes that happen in the underlying visual pattern, which can be extracted using AI. So you will see that a lot of what I'm talking about AI is related to images, because the most significant advances that have come in AI have been in images, audio, and text. And there's a reason for that. There's a reason because of certain structure in that data and structure in the neural networks that match to operate upon that data, which I'll talk about shortly. So we can make this task even more complicated, and we can say that let's predict the outcome of a particular treatment given to a particular cancer by looking at its medical image, primarily pathology, because there's a lot of detail in pathology. The task that is not very easy for AI is to explain itself. So it's a complicated pattern recognizer, but it is not an explainable system. The At least the state of the art AI that we hear about in the news for face recognition, self-driving cars, and increasingly for oncopathology and oncoradiology. So to put that same information in another perspective, so the things that you see on the left hand side, clinical data, imaging data, etc., those you can think of as downstream things that we collect, data that we collect, and that you see on the right is upstream, whatever we want to predict. So anything on the left can be used to predict anything on the right. The more information we pick up from the left, the better our prediction will be for things on the right. So we start with clinical data, imaging data, and then based on that, we may want to order some molecular tests. And based on that, we would want to give a precision diagnosis. And with that, we would have a treatment plan. So for example, if it is HER2 positive breast cancer, then the treatment plan would involve Herceptin or trastuzumab, which is an anti-HER2 therapy. And similarly for EGFR lung cancers, there will be a specific therapy, etc. And then finally, once the treatment is given, after a follow-up, we will get the outcome. So we can use any of this data to predict what is going to be the treatment plan or what is going to be the diagnosis. Or we can take all of this data and match it with a treatment plan and predict what is the outcome. So we go from left to right. So within this realm, we can try to build any kind of AI model. AI models are not going to be 100% accurate, and they are not going to be as bad as flipping a coin either. They are going to be somewhere in between, depending on what is the quality of data, what is the ease of the problem, and what is the quantity of data. So we want to keep that in mind, and there are some other challenges with AI that I will talk about in a short while. But don't we cannot go to either of the two extremes, that AI cannot do anything and AI can do everything. Neither of those two is a reality. So basically, what is AI? AI is the task of building algorithms that take data and think of that data as experience, and based on that they get better at a particular task. Just like how we learn to walk, we fall several times and then we realize if our legs are going this way or that way, that means we have to apply pressure another way, and so forth. And with a lot of examples of failing to walk and successful balances, we learn how to balance ourselves. Similarly, in vision, we look at various objects, we touch them as a baby, we put them in our mouth to get a sense for their shape and texture. And based on that, we realize that there is a visual explanation for the shapes that I see. And based on that, we form a model of the world. What is the sweet spot of AI? AI will work better when we have lots of structured data. So there are two key operative words. One is lots, the other is structured. If we don't have structured data, AI models are not that successful. The most successful models are for structured data. And now with deep neural networks, there's a way to scale the models up in their accuracy when we have lots of data. So when we want to have high prediction accuracy, but we don't demand explainability, because AI models are becoming more and more like a brain, a mammalian brain, that we have lots of small units working together to give a complicated output, but the explanation of actually how it happens, that is not very clear. And the underlying models are complex but stationary. What I mean by stationary, that if you train the model today, tomorrow the data characteristics are not going to change. So an example would be that if you are looking at pathology images, they will look the same way 10 years from now if we are using the same technology. On the other hand, if you're looking to predict people's age based on their clothing, that fashion is going to change in 10 years. So that will not be something we can predict. So in general, you will have two parts. One is training, the other is testing. So during training, we'll take inputs and labels. This is where the effort is. So we have to get lots of clean inputs, which means lots of images, clean images, and labels means annotating the boundaries of what we are trying to teach AI, that this is DCIS. And then labeling it that this is DCIS and this portion is IDC, etc. So that's the laborious part. But after that, we get a model if we have collected enough of that. And then we can use the model with new inputs and it will produce the labels for us. But inside AI, it's actually not magic. It's basically just an equation. So here you can see a simple equation to predict height from age. So if I plug in age into a formula like this with appropriate values of A, B, and C, I will be able to predict height from age up to a certain accuracy, right? So assuming that as people age, the height increases and saturates. So this is the kind of uh, graph that this equation is modeling. The only difference with AI is that instead of like just three unknowns, A, B, and C, and just one input age, we will have millions of inputs and we will have tens of millions of unknowns that it will try to assess looking at the training data. So we no longer can use simple statistical tools. We have to use large scale optimization techniques and machines that have multiple tens of thousands of cores called GPUs. So we use that with a lot of processing power to basically uh, do this analysis. So for example, if you have an image with 1000 by 1000 pixels, right? So let's say this could be a radiograph. So 1000 by 1000 pixels means it has 1 million 1 million inputs, 1000 times 1000. And the number of unknowns, which are weights and biases inside a neural network, could be 10 million to 100 million weights. So these are the weights in this simple equation. Instead of that, we will have 10 or 100 millions of those. So basically, it's trying to find these complex associations between whatever structures it sees and then whatever it is trying to predict. The type of data on which AI has started to excel a lot are things that come in either a temporal or a spatial order, and that's why text, speech, and images is where most of the advances in AI is. So if you look at an image, if you blow up, let's say, the eye of this cat, you see that the pixels are not in a random order. The order of two pixels that are neighboring to each other, that matters, because that defines the shapes and the edges and so forth. Same is the case in medical images, and same technology for whatever is used for recognizing cats versus dogs can be used for recognizing different sub types of cancer. I will skip this part about neural networks. Okay, I'll just show you where AI has come so far. So back until 2015, there used to be a challenge called ImageNet challenge, or large scale image recognition challenge. That challenge has more than 1 million images with their labels, and those labels can be in one of the 1,000 classes. So what is a label? That this image is a cat, and not just a cat but a tabby cat. Okay, this image is a car, and not just a car, like probably some model of a car. This is a bird, this is a plane. So 1,000 categories of everyday objects. And neural networks, or actually before neural networks, the um, different computer vision techniques used to compete on getting the error to be low and low, or accuracy to be high and high on those. And what they would measure is that if we look at the top 5 predictions for a particular image, then what is the percent of error that the correct prediction is not in the top 5. And some images were not very easy. Even so, for example, if you take a dog and take an image from the top view, it will look like a goat. So even humans sometimes get confused. So even human accuracy was not with 0% error. So human accuracy was somewhere around 3% error, or 4% error. And back in 2012, there was a real promise that we are moving towards that. And in 2015, the neural networks started to become at par with human. Now, what does it mean to exceed human accuracy in subsequent years? What that means is that the person who gave the label was an expert in labeling that image, but human accuracy was average performance of a single human, not from a committee of experts. So now the neural networks have slightly exceeded that accuracy, and that created a whole bunch of excitement about, can we apply it to more niche and expertise oriented fields such as oncology. So back to oncology, we can structure these problems as classifying between cases and controls. This is one of the limitations of AI, that the problem has to be very, very structured. You cannot ask it a question that is quote unquote out of syllabus. If you ask a question that is out of syllabus, it will give you a garbage answer, but because it is forced to give an answer. So for example, if you train it on cases malignant versus benign, it can classify between those. Grade 2 versus grade 1 or 2, ductal versus in situ in breast cancer, for example. Or now we can go to molecular markers by looking at just H&D pathology. Can we predict between EGFR mutation versus wild type in lung cancer, for example? And there is evidence that with certain level of accuracy, it is able to predict that, not with 100%, but 70-80%. Then even more exciting is that, can we predict a treatment responder versus non-responder, or a short-term survival versus long-term survival? And this is where the real value is. The more data we start to collect and use on AI for this, the better answers we'll get in the future. Another perspective of the same problem is that, given an image, we can ask AI to classify it into whether it is a calcified nodule, yes or no. Okay, or we can ask slightly more tougher question, not just classify the image, but mark me where the calcified nodules are. We can ask even tougher question that give me precise boundaries of the nodule. And this kind of question can also is also relevant to pathology. And we can ask not just mark the nodules, but color them with different colors if they are two separate nodules. So this is becomes more important when objects are overlapping. For example, when you're looking at nuclei in uh, in uh, in images, in pathology images. So for this, what is important is that we take thousands of images where we have actually done this annotation manually. An expert or a committee of experts have done it, because the more precise data we give AI, the better it will learn. And it learns with more examples, unlike humans who need, let's say, within 5 6 examples you can teach your resident a particular concept, but AI would probably require a few hundred to a few thousand examples to learn as good as your resident. But once it learns, then that program can be transferred from computer to computer, and it can even go to remote places and do the diagnosis as good as what you taught it. uh, so this is an example of work from our lab in collaboration with Tata Memorial and UIC. Here we were trying to detect HER2 mutation with just HND stain breast cancer, and we built a three-stage pipeline using AI. The first neural network just detected all the nuclei, which are these white dots. The second one classified them as cancer, non-cancer, and the third one classified cancer nuclei as HER2 positive or negative. And for this, basically, we had to take a lot of HER2 positive cases and annotate that this is the cancer region, and also take HER2 negative cases and annotate that these are the negative regions, but cancerous regions, and so forth. And finally, after training on held out patients, it's able to mark all the HER2 negative cells, non-cancer cells, and HER2 positive cells uh, with this red color on HND. And we are, for reference, we are showing a serial section of IHC just to confirm that it is doing a good job. So now, if the IHC exists, why do we need this? Actually, we don't. We probably only need it for cases where IHC is not available in a lab. But the exciting part about this is that if we can train it to recognize HER2 mutation from HND, what else can we do? Can we make it recognize mutations for which the IHC does not exist, right? So if we at one time effort we create uh, the combination of pathology image and their RNA or DNA testing, and based on that, now we train to predict the RNA or DNA test using the HND stained pathology. Then at least for a quick test, we won't be needing to do the molecular test, or at least to screen things out, and then molecular test will just be a confirmation after that. So it can reduce costs, it can bring tests to places where those don't exist, and so forth. So we did the same with BRAF IHC. I will skip that. So now we have more advanced models that don't even need annotation. You just label the whole image, whether it's BRAF positive or negative, and it will even find out regions where the signal is coming from. So this is the region of BRAF positive signal. This is the region of BRAF negative signals. This is classic papillary uh, histology, whereas this is like oncocytic cell uh, cytology. And we did not teach the neural network that to find particularly these uh, visual signatures. It automatically learned just by learning from the DNA labels. So challenges to AI is that if the data is unlabeled, then it won't work. If data is less, it will not work. If the data is poor, it will not work. If there are changes in data, you change the equipment, you use a different Tesla machine for an MRI during training, and you use another high powered Tesla machine during testing, then it will not work. If you ask it a third, you train it for 5 different classes, 5 different subtypes of cancer, and then you get something like metaplastic for which you didn't train it, it will not be able to tell you that it is something out of syllabus. And if relevant data is not captured, or the problem is too complicated. So there are different life cycle of AI. You first have to ask the right question, formulate the model, get the data, and then train and validate it and package it. At each point, some human is involved who should have the responsibility of passing the baton to the next stage of humans about how to use it correctly, how to not use it out of context, and how to keep monitoring and auditing AI after it has been deployed. So AI can definitely help doctors. You can think of it as another test, just like you use molecular tests, and not think of it as a replacement. I don't think it's going to be a replacement. It's more important that future doctors be taught how to use AI tools, and it becomes another test, and they know how to critically ask questions beyond what the AI vendor is telling them, and ask them in which situations has it been tested, on what population it has been tested, etc. On what equipment should I collect my data to be able to apply this AI, on what equipment it has not been. So these are some of the myths. That's my last slide. That AI is accurate on all problems. That is not true. AI is not usable for any problem. That is also not true. It is constantly learning on its own. That is also not true. Every time you collect data, 1 million images you have trained on it, you don't want AI to be constantly learning, because there is a chance that it will forget the old knowledge that it has learned. And that's a very dangerous type of AI. It may only be justifiable to use that in certain situations, not in medicine. In medicine, after 5 years, when your data repository has increased, you release version 2 of that AI with due testing and validation. AI is not a sentient being, it's just a big equation, and it is too difficult to use or understand. That is also a myth. With little bit of training, people can ask critical questions of AI and use it. Thank you.